Hey guys, welcome to another edition of the Right Way Wednesday. Today I thought I would talk a little bit about frequency and duration of our services and how we order that. And the reason I want to talk about this is one of the things that we see a lot when we're auditing plans of care are patterns really in how we're ordering frequency and duration that don't always seem to match necessarily the goals, the complexity of the patient, or the discharge needs of that patient. So I want to talk a little bit about best practices when we're looking at how we determine what the frequency and duration of our services is going to be. So the first thing I want to just throw out there is Chapter 15 of the Medicare Benefit Policy Manual actually says this. The amount, frequency, and duration of the services must be reasonable under accepted standards of practice. And the contractor, that's us, shall consult local professionals or the state or national therapy associations in the development of any utilization guidelines. And what they're saying there is that we have to use standards and practices that are accepted by the industry and that make sense based on the condition of our patients. What they say as well is that the frequency or duration when they're looking at the medical necessity of the services that are provided isn't the sole factor. That's not all that they're looking at. But given the other factors, such as condition, progress that is made or lack thereof, the treatment type, the frequency and duration that we order really should provide the most effective and efficient means necessary to achieve the patient goals. So that means that may not always mean that we're providing 5-day-a-week treatment or 3-day-a-week treatment. It may mean that we do something completely different than what we might be doing for patient A, for patient B. So it might be clinically appropriate, for example, and medical necessary that the most efficient and effective way to provide therapy to a patient is through short-term intensive rehab. So maybe 7 times a week for 2 weeks, or 5 times a week for 3 or 4 weeks. Something more intensive on a daily basis might be the most efficient and effective way to help our patients meet their goals. Now, it may also be clinically appropriate, medically necessary, and most efficient and effective to provide longer term and less frequent treatment. So maybe 3 times a week for 6 weeks. Maybe we need to be in there less often, but for a longer period of time to meet those individual goals for that patient. It might also be clinically appropriate to taper the frequency of visits as the patient is progressing. And you can think about this on evaluation, what that patient might need. They might be then progressing towards an independent or a caregiver-assisted management program with the intent of, say, going on to the next level of care. So, for example, you might start at 5 or 7 times a week treatment for a couple of weeks and then taper that treatment down to, say, 3 times a week for a couple of weeks, and then maybe even 1 time a week for a couple of weeks as you move towards that independence. So you want to consider that as well. All right. Or maybe you start with 3 times a week and then taper that down to 1 time a week over a period of, say, 6 weeks. Again, whatever is the most appropriate for your patient. You might also want to consider that when you're looking at maybe some of those more clinically complex patients, they might need more frequent treatment, more daily intervention because of their needs and their goals and where they're heading. But maybe they can't necessarily tolerate PT, OT, and speech every single day for intensive treatment. So you might want to consider in some of our patients that sort of flexing that delivery with other disciplines might be appropriate. So for example, maybe OT goes in 4 times a week on Monday, Wednesday, Friday, and Saturday. And speech therapy or PT goes in 3 times a week on the other days during that week. So Sunday, Tuesday, and Thursday. That way the patient gets daily intervention because of their needs, but they're not overly taxed. All right. So those are just some different scenarios. Clearly, obviously, those aren't all of the scenarios, but I just want you to think more individually about your frequencies if you're not already doing that. It's not just about payer. It's not about payer. It's really about patient needs. While we do have to meet payer guidelines when we're talking about specifically Part A and meeting that daily skilled need, we do still need to consider the individual aspects of our patient and how that might impact your frequency and duration overall. All right, so best practice in general. Consider the potential need for tapering or frequency at the onset of skilled treatment. You need to be thinking about that right away. And if appropriate, include that tapering plan in your initial plan of care and your clarification orders. Really think ahead, think discharge planning, think what is this patient going to need in order to meet those goals and be as independent or as autonomous as possible, right? Ensure your documentation supports any changes in frequency and duration. And when I say that, I don't just mean an order. I don't just mean a simple note in a UPOC that says your frequency is going to say increase or decrease. I mean really making sure that the narratives in your documentation support the clinical need for whatever frequency you choose to begin with, and then any changes to that frequency there on out after the plan of care has already started. It's really important that we support any changes with a clinical need, and we have to do that in our documentation. All right. And then you want to think about, you want to get a physician's signature on a UPOC and updated clarification orders if that change of frequency wasn't pre-planned and results from a significant change in the patient's condition. Okay, so it's really important that you get that signature and you inform the physician and get that physician agreement with that. All right. Now, again, everything we do, everything that we provide our patients should be clinically appropriate, medically necessary, and meet the needs of our patient and be skilled above all. So when you're looking at frequency, don't just get into a habit of ordering a specific frequency and duration for every patient based on their payer source. You need to think about their clinical and individual needs and order it based on that. Thanks for sticking with me today. Happy Wednesday. Hopefully you have better weather than we do. Again, in South Carolina, it seems like the rain never stops. So I think we're going to get some more today. But thanks for joining us. If you have any questions, let us know in the chat box below, or you can shoot us a question on the Facebook page, and we will do our very best to answer it and give you the guidance that you need. Thanks so much, and happy documenting.